Good afternoon. I would like to thank Professor Diamanti for the kind invitation to this really nice meeting. And after the photograph that we had all together, we will proceed to a short overview of the topic of thyroid dysfunction secondary to cancer immunotherapy. My job is really easier because we have already had a very nice introduction by Professor Popovich about this drug class. And that talk really focused on the pituitary. So I'm going to focus on thyroid dysfunction, which can be either primary or secondary. So I'm going to speak about mainly about primary thyroid dysfunction. So cancer immunotherapy is really based on the idea of using our own biology to treat cancer, which is really a revolutionary area of oncology. We have evolved several immune checkpoint proteins and mechanisms to prevent the immune system from harming the host when reacting to a foreign antigen. However, malignant cells have developed mechanisms to evade the human immune system. There are at least 7 different drugs that are currently approved by the FDA in this class. And you can see that they are used with several indications, including melanoma, non-small cell lung cancer, renal cell carcinoma. Okay, thank you. But also hepatocellular carcinoma, head and neck cancer, certain kinds of colorectal cancer, etc. Manipulation, however, of the immune system is not without side effects. And therefore, various autoimmune toxicities known as immune-related adverse events are observed. And in particular, concerning the endocrine system, those include hypophysitis, thyroid dysfunction, as well as, more rarely, insulin-dependent diabetes. It's not only the endocrine system that is involved. As you can see here, nearly all systems in the body can be affected by immune-related adverse effects. And the most common are probably the skin and the GI tract, but also patients can develop pneumonitis, arthralgia, etc. With the red arrows, you can see the prevalence of endocrine side effects. And what I think is important is to introduce ourselves to something that is very commonly used by oncologists, which is this grading system of adverse events. Which ranges from G1 to G5. So G1 is when side effects are asymptomatic or patients have very mild symptoms, but G2 refers to patients who have moderate symptoms and they are able to perform their daily activities. G3 to G4 are when patients have more severe symptoms that may interfere with their daily activities, and G5 is death. But how do these immune checkpoint inhibitors work? I'm not really an immunologist, but I'll try to explain in simple words what is the concept behind the mechanism of action of these drugs. So really the first thing that happens physiologically during a T-cell activation, that is the first activation signal, is initiated when a T-cell receptor binds to the major histocompatibility complex presenting an antigen or an antigen presenting cell, as you can see here. The second activation signal is initiated when the CD28 receptor binds to the B7 ligand on the antigen presenting cell here, and this process activates the T cell. However, there are these CTLA-4 receptors on T cells that they function as a checkpoint. And therefore, what they do is that they inhibit T cell activation by competing with binding to these B7 ligands, and therefore they negate the effect of the second activation signal. So let's see one of the major CTLA antibodies that are used in this class, the ipilimumab. What does it do? This binds to the CTLA-4 receptor, and therefore it indirectly increases T cell activity. The other thing that tumor cells do is that they are clever, and they evade T cell detection by mimicking an antigen-presenting cell with PD-L1 ligand. And this deactivates the T cell. However, nivolumab and drugs like nivolumab, they can block this PD-1 to PD-L1 interaction, and therefore they can upregulate the immune response, and this leads to inhibition of tumor growth. So to come to a more clinical context, endocrinopathies, as I said previously, with immune checkpoint inhibitors include hypophysitis, which is typically induced by CTLA-4 antibodies, and primary hyper or hypothyroidism induced by both classes of drugs, both the PD-1, PD-L1 or CTLA-4 antibodies. Importantly, the symptoms can be very non-specific, and it's easy for the clinician to think that these symptoms may be related to cancer rather than endocrinopathy. And rarely, these drugs may affect the adrenal glands and cause primary adrenal insufficiency, or the pancreas and cause autoimmune type 1 diabetes. Endocrinologists know, of course, that it's important to differentiate between primary and central hypothyroidism, which is usually characterized by a low free T4 level and a low normal TSH level. Things may be more complicated, however, because some of these patients can be unwell, and we all know that during acute illness you may get what is known as a low T3 syndrome. Not to mention that a lot of those patients may have low albumin levels, and measurements of serum cortisol may be inaccurate as well when one wants to diagnose hypophysitis. The mechanism of primary thyroid dysfunction in these patients is unclear, and it may be related to disruption of immune tolerance by PD-1, PD-L1. Interestingly, there are reports that polymorphisms in the CTLA-4 gene may relate to a higher incidence of autoimmune thyroid disorders, and the presence of thyroid antibodies has been associated with an increased incidence of drug-induced thyroid autoimmune disease. The majority of those cases is related to painless thyroiditis. So initially there is a thyrotoxic phase, which can be missed, and this is usually followed by a hypothyroid phase. Graves' disease and Graves' orbitopathy have been described very rarely. Primary thyroid dysfunction can occur with both classes of drugs, but is probably a little bit more common with the second one. And you can see here that the incidence of primary hypothyroidism is approximately 6%. Hypophysitis is more common with the CTLA-4 antibodies, up to 9%, and secondary hypothyroidism, 7.6%. When one uses a combination of those drugs, then the incidence is even higher, with hypothyroidism up to 13.9% and hyperthyroidism at 8%. You can see here same thing, that when those drugs are used in combination, thyroid disorders are 23%, and in some reports even up to 30%. As I said previously, the clinical presentation can be subclinical, really not clinical, and therefore one has to monitor those patients regularly. Screening is by measuring TSH and free T4 at the baseline and also during immunotherapy, and it is advisable to measure TSH and free T4 at least monthly in the beginning for 6 months, and then every 3 months for the next 6 to 12 months, followed by 6 monthly during the second and third year of therapy. When there is clinical suspicion of thyroid dysfunction, we measure TSH and free T4, and if necessary, we can go on and measure antithyroid antibodies as well. When there is persistent hyperthyroidism, and there is a question of whether the patient has Graves' disease, then a thyroid scan may be advisable. And of course, if there are elevated TSH receptor antibodies or orbitopathy, then a diagnosis of Graves' disease can be made. But as I said, this is very rare. Perhaps the largest study to date on the natural course of thyroiditis is from Houston, from MD Anderson. And they included 657 cancer patients treated with immune checkpoint inhibitors in a retrospective manner. The inclusion criteria were that those patients had normal baseline thyroid function, and all of them developed thyrotoxicosis. So they wanted to include only patients who had thyroiditis and they were able to follow the natural course. And what they found is that the median time to thyrotoxicosis was about 5 weeks. The median time to hypothyroidism was 10 weeks. 84% developed hypothyroidism, and only 9% recovered from this transient hypothyroidism. Apart from that, the authors mentioned that most patients develop permanent hypothyroidism, and this is interesting because drug-induced thyroiditis by other drugs, such as amiodarone, lithium, etc., can cause permanent hypothyroidism in about 10 to 20%, so much less compared to checkpoint inhibitors. The majority of patients were asymptomatic, and 1/3 that were symptomatic during the thyrotoxic phase were able to be managed conservatively with beta blockers. Importantly, all patients were able to continue their immunotherapy for cancer. The median dose of levothyroxine was slightly less than that for primary Hashimoto hypothyroidism or surgical hypothyroidism. And another observation was that those patients who were exposed to glucocorticoids needed somewhat less in terms of a dose of levothyroxine. In terms of management, glucocorticoids are not routinely recommended for the thyrotoxic phase, and usually, as I said, beta blockers are sufficient if the patient has tachycardia or tremor. For hypothyroid patients, we use thyroid hormone replacement, and cancer immunotherapy, the advice is to hold it for side effects that are grade 3 or more and restart when the grade is less than 1. Discontinuation is not recommended, and one has to remember that these patients have no other option. In terms of secondary hypothyroidism, which is related to hypophysitis, the overall incidence of hypophysitis, as you can see, is 9% approximately, and secondary hypothyroidism is 7.6%. The onset of symptoms is about 6 to 12 weeks after treatment, and interestingly, this is more common in men as compared to the idiopathic autoimmune hypophysitis, but this may be due to the fact that a lot of those patients had melanoma, which is more common in men. The mechanism may be related to complement activation from antibodies against the pituitary gland. Presenting symptoms, common presenting symptoms are headache, fatigue. As I said, they can be non-specific. Hyponatremia is quite common. MRI may or may not show an enlarged pituitary gland. Morbidity is mainly caused by secondary adrenal insufficiency, and the most common pituitary hormone abnormalities are ACTH and TSH deficiency. What is important is that adrenal insufficiency from this kind of hypophysitis is usually permanent. However, recovery of secondary hypothyroidism has been described, as well as recovery of the gonadal axis. So routine screening is necessary for hypophysitis as well. I'm not going to go into details. And the management may involve the use of steroids. High-dose steroids are advised for patients who are really critically ill, such as those with significant hyponatremia, severe headaches, visual abnormalities, or significant pituitary enlargement. However, there are reports that if one uses smaller doses, that is, even replacement doses, that might be adequate. And of course, if pituitary insufficiency develops, we may use hormone replacement therapy. Another interesting observation is that those immune-related endocrine events may be associated with better survival. So there is a correlation between the two, and this might be due to bias, because those patients are monitored for over a longer period of time, but it might also indicate that this is the result of an autoimmunity, that autoimmunity being indicative of a non-specifically overactive immune system that results to increased anti-tumor efficacy. And you can see here that patients with metastatic melanoma had a survival that was more than twice that of patients who did not develop hypophysitis. There are now updated guidelines, so oncologists know how to monitor those patients and obviously when they need to refer those to you. So in summary, with a rapidly expanded immune checkpoint inhibitor use in cancer, many patients are affected by endocrine immune-related adverse effects, which may be up to 30%, and thyroiditis at approximately 6%. Both anti-CTLA-4 and anti-PD-1 therapy are associated with primary thyroid dysfunction, and thyroiditis is characterized by a rapid development of a predominantly asymptomatic thyrotoxic phase, followed by hypothyroidism that may require lifelong thyroxine replacement therapy. Secondary hypothyroidism due to hypophysitis is mainly associated with anti-CTLA-4 antibody treatment. And to conclude, awareness of the frequently subclinical presentation, regular monitoring, early diagnosis, and cooperation of the oncologist with the endocrinologist in those cases that are difficult may result in reduced morbidity. Thank you for your attention.